We have Professor Ken Sikaris with us today, and he's probably best known to many of you as Professor Blood from that Sugar film. But if we give him a little bit more of a formal introduction, Ken is a chemical pathologist and worked at St Vincent's Hospital in Melbourne for quite some time. And he is currently working at Melbourne Pathology, where he specialises in a number of things, one of them being cholesterol and also improving the quality of clinical laboratory medicine. So in our simple terms, he is our go-to expert when it comes to cholesterol and analysing bloods. And for me, I'm often emailing Ken and asking him about tricky clients when bloods come in that are just not making sense to me. And he always has, answers for me, but based on really sound science. So I really know that I can trust him with his answers. So Ken, firstly, welcome and thank you so much for your time today.
Thank you, Vicky. Yes.
Right. So to kick things off, perhaps you could begin with explaining to us what cholesterol actually is and why it's been given such a bad rap over, the last however many years.
Well, cholesterol's a special type of fat. The body uses it to control the type of fat in the body. So, a lot of our body is made up of fat, but fat, as we know, is a bit of a sloppy thing. And one of the main uses of cholesterol in the body is to stiffen up that fat so that it can make cells and it can make, transport structures and so on. It's also such a specialized fat, we can make hormones out of it. So it's quite a natural thing. But the thing that gave it a bad rap was that people discovered that when people were dying at a young age from heart attacks, they looked in the blood vessels of those people and they had atheromas, little blockages in their blood vessels, which had cholesterol in them. And so suddenly this natural thing started getting a bad name because it accumulates in blood vessels and causes disease. But the problem was that people were blaming cholesterol, which was really the messenger of the disease rather than the mechanism of disease. Why was the cholesterol getting into blood vessels? It wasn't really just because there was cholesterol around, because we all have cholesterol around. There was something else that was causing that. And so recently people have been trying to work out, well, everyone's got cholesterol in their bloodstream. What type of cholesterol gets into the blood vessel walls and cause blockages? And most of your listeners would have the idea that now we try to split things up into good and bad cholesterol. The good cholesterol, which is HDL, doesn't end up in blood vessel walls. It actually helps clear cholesterol from tissues and blood vessels. And the so-called bad cholesterol, which is usually called the LDL, is thought to be the one that ends up in blood vessel walls. But that is also not true. All of us have LDL cholesterol in our blood, and it doesn't end up in the blood vessel walls of everyone. There's something else that changes LDL cholesterol and makes it bad. And really, to cut that long story short, it's the other fats that make the LDL particle bad, the triglycerides. So when triglycerides, simple fats, accumulate in fat tissue or the liver or the blood vessels, they're damaging and they change what should be a healthy particle, the LDL particle, into a bad particle, which we call small dense LDL. So really, in laboratory testing, we don't look reporting cholesterol on its own anymore. I mean, there's a guideline that's saying we shouldn't be reporting total cholesterol at all because it's so misleading. Mm-hmm. That's not the problem. The new guidelines also say we shouldn't be reporting bad cholesterol or LDL on its own, because that's misleading as well. And so the new predictors, like the ratios, which we can talk about in a little while, but the new predictors like the ratio are meant to tell us, is the LDL becoming bad? And so the total cholesterol HDL ratio and triglyceride levels tell us that. But anyway, it's very hard to get that when we've had it drummed into us for the last 30 or 40 years that cholesterol is bad, and that, well, some of it might not be bad, but some of it's bad. We just can't get away from this issue of blaming cholesterol when the problem is not cholesterol.
Right. Okay, well, that makes sense to start off with. So, when somebody heads off to their doctor and they get given a referral to get a blood test, they then have the cholesterol profile done, and they get given a whole stack of numbers for total cholesterol, HDL, LDL, triglycerides, and then they're given a few ratios. What should they be looking at to understand all those numbers a bit better? What's important? What's not, all of that sort of detail. Yeah.
So the total cholesterol is not important according to every specialist in the world. There is a problem though in Australia, because when people are prescribing statins, the rules regarding statin use, which have been around for 20 or 30 years, still talk about total cholesterol. They're out of date by 30 years. Anyway, but total cholesterol you should really ignore, and I apologise on behalf of the pathology community that we've put it on a report, because it just creates angst without any particular meaning.
Yeah. So
we're not interested in the total, we're interested in where that total is, in the LDL or the HDL. So probably they're the first things, breaking down the total into the LDL and the HDL. So the first thing I would look at is the HDL, because that's the good cholesterol. That's forms of cholesterol that are actually good for you, and it should be as high as it can be. Now, in a man, it should be well above 1, and in a woman, it should be well above 1.3. It's about a quarter of Australian men who are below 1. It's terrible.
Yeah.
And really one of the goals in the low carb diet is to get that in a man well above 1, and typically 1.3 or 1.5. That would be a really successful outcome with the diet, to increase the good cholesterol.
Yeah.
Now the LDL I would also ignore. Again, the LDL is used as a target for statin treatment and a monitoring marker. It's got really nothing to do with predicting risk or with diet. And we know that because that's why we've created all of those ratios. The ratios are going to tell us whether that LDL reading is relevant or not. And the ratios that are... Now, there is a simple measure that tells us whether the LDL's likely to be harmful or not, which is the triglyceride level. And triglyceride levels, it's a very simple issue. If your triglycerides are high, there are fats in your body that you're not using. And it usually correlates to all that fat below the skin and in your gut that you're not using, and the fat that accumulates in the liver. So high levels of triglyceride are really just a sign that you're not using fat. Whereas if with the diet, the low carb, high fat diet, where you teach your body to use fat, paradoxically, you're eating fat, and the thing that happens to triglyceride, which is a measure of fat, is it falls because you are using it now. You're not only using it in the blood, but you're starting to use your fat stores and losing fat.
Yeah.
So the fat, this triglyceride level tells you whether there's a block in fat metabolism. And if there's a block in fat metabolism, as I said before, your LDL can be harmful. So to me, I look at the triglyceride level in the simple approach. If the triglycerides are over 1.5, then it's likely that any LDL measure you've got may have some small dense LDL there. It's not 100% predictive, nothing is in medicine, but it's very likely. Now, here's another trap with your reports, because maybe 10 years ago, labs varied in what cutoff they put for triglyceride. What is a healthy triglyceride? Some said 1.5. We've been using 1.5 for quite a while. Some said 1.7, some said 2, some said 4, some said 10.
Oh.
Like, back then, we couldn't care less about triglycerides. No, everyone thought they were useless, and what do they mean? Now that we know what they mean, we're much more focused on triglycerides. And even the National Heart Foundation pushed from 4 down to 2, down to 1.5. And a bit like the low HDL, they do go hand in hand. Patients with low HDLs have high triglycerides above 1.5. And it is over a third of Australians who have triglycerides above 1.5. Now, when we put a cutoff of 1.5 on our reports and it scares 1/3 of Australia, we've got an abnormality on the report, a lot of doctors say, well, we don't know what to do about that. How do we, do we need to lower triglycerides? How do you do that? It's diet. Well, diets don't work. And there's sort of this resignation that high triglycerides may be important, but there's not much you can do about it. Whereas anyone in this sort of low carb movement knows there is something you can do about it. Very easy thing to fix with most people in the diet. So triglycerides are so HDL and triglyceride, they are the important two measures, but the ratios give us a clue like that. So now the ratio on every report is the total cholesterol to HDL ratio.
Mm-hmm.
Now, it's a very complicated thing. I've told you the total cholesterol is not important. HDL is important. So how does dividing something important like HDL and comparing it to something that's give you something that's meaningful?
Yeah.
Well, it does. And it does so because total cholesterol correlates with LDL and HDL correlates with triglyceride. So if the HDL is low, which increases the ratio, it means you've got small dense LDL. And if the total cholesterol is high, which means you might have a lot of LDL present, it tells you the other aspects. So HDL tells you how much of your LDL is small and dense, and the total cholesterol tells you how much LDL you're likely to have. So those two things together sort of compound each other. How much LDL do you have and how much of it is small and dense? They're the only two things you need to know. And that is my favourite ratio.
And is there a particular,
to a degree.
Sorry,
Yeah.
Is there a particular number for that ratio that we're aiming to be below?
Yes. I mean, typically we talk about 4.5 as the cutoff in medicine, and it's a bit like the cutoff of 1.5. So once you've got a total cholesterol HDL ratio of over 4.5, it's likely you've got small LDL and a significant amount of it. But ideally, you shouldn't be anywhere near that point.
Yeah.
And so ideal levels with triglyceride, you shouldn't be above 1.5. And ideally, you should be down around 1 or less.
Yeah.
And so similarly with the total cholesterol HDL ratio, ideally you shouldn't be above, you shouldn't be above 4.5, but ideally you should be well under 4. And most people on a low carb, high fat diet that do increase their HDL from less than 1 to 1.5, that'll change their ratio from over 4.5 to 3.5 or so, which is ideal, those sort of low levels. So it's hard to make things black and white in medicine. There are some things that are black and there are some things that are white, and there's this stuff in between. And so I prefer to have this, so triglyceride less than 1's ideal. Over 1.5 is no good. In between, you're on the journey, either the wrong way or the right way.
Fair enough.
So
you've mentioned quite a number of times these small, dense LDLs.
Yes.
If somebody does have a higher triglyceride and a lower HDL, and therefore the prediction is that they have this small, dense LDL, is a low carb, high fat still appropriate for them? Would you be looking at medication for these individuals, or where would you be going?
It depends on how bad it is. So, and when I was at St Vincent's, I worked in a lipid clinic, a specialist clinic. So when GPs ran into problems with cholesterol, they'd send us their patients. And there were some patients, which amount to about 1 in 1,000 patients in Australia, rare patients, who have a familial problem. Their body sort of naturally accumulates LDL. And if that LDL becomes small and dense, it's disastrous. And these people have heart attacks in their 20s.
Yeah.
Now, for those patients, you could say, so you've got a 25-year-old man who's got this diabolical history, watched his father die, and you say to him, well, look, we want to try a diet, and in a year or two's time, we'll see how it works. Well, they may not. That's too big a risk. And it's also the same with people who've already had a heart attack and have got those bad numbers. They're at a huge risk. You don't say, look, don't worry about the heart attack you've had. Let's just change your diet. If there's a drug that can reduce the small dense LDL, like statins do, that's what statins do. They don't lower total cholesterol. We said total cholesterol is irrelevant. The fact that statins lower total cholesterol is irrelevant. The relevant thing is that they are the medication that lowers small dense LDL. And if you don't have another quick way of lowering small dense LDL in high-risk patients, you should be on a statin. But that's not the end of it, because nobody really wants to be on medications for the rest of your life. If you can then achieve your goals of losing weight, reversing your diabetes, doing all of that thing, then you might be able to get off the statin. And that so I do. I know a lot of the low carb community don't particularly like me because I still support the use of statins in certain situations. But there are, I suppose, medical practitioners, we remember the people that die, and we wish we could have done something to prevent it. And so we naturally want to protect those really high-risk patients. And when we've got something, whether it's, a foreign chemical that helps them do that, we would gladly use it.
Yeah, absolutely.
And we won't use it if we've got another perfect solution. And for most people, over 90% of people, the perfect solution for weight and for diabetes and for the risk of heart disease is to lower their carbohydrate intake, fat adapt, and reach their health goals. So, so I do support the use of statins in high-risk situations, and once you achieve your goals, you can get off them.
Great. And if somebody's just starting off on a lower carb approach, and their triglycerides are high and their HDLs are low, how long do we usually see until they start seeing good changes in these numbers?
In my experience, they'll see changes in 3 to 6 months. So, and that's, really, if you stick to the diet religiously, you'll lose a lot of weight in the first 1 or 2 months, but you won't reach a plateau, that low point in your triglycerides and everything immediately, but they will change pretty quickly. So if you're lucky, it'll take 3 to 6 months. Some people take longer, and by that I mean most people will achieve those changes within about a year. There are some that take even longer than that. And I'm not really sure in my mind for each of those people whether it's because they haven't been able to be really strict with the diet, or whether they do have another thing that makes them different.
Yeah.
They may have severe diabetes, which is taking a while to resolve. So there are some patients that take a year or two to get to those goals.
Mm-hmm.
And it's very much like the weight goal. I mean, whilst we all might say, I want to get a BMI of 25, it was considered overweight. And so we might say, well, as soon as I get to 24.9, I'll be happy. Well, you may not be.
Yeah.
Because, say Asians and Indians, they still look a bit overweight at 25. Yeah. So, individually, our healthy point may not be at 24.9, it may be 23.9.
Yeah.
And usually, as you'd know, Vicky, people, usually when they hit that point, they know it. I'm not feeling that healthy by losing any more weight. I'm feeling 100% at 24.
Yeah.
But if you want me to get to 21, I feel terrible.
Yeah.
So everyone, sort of discovers that personal goal, and so it's and that personal goal. So you may be disappointed because your BMI has hit 24.9 and your HDL's not come up above 1.5, but it may be that your target should be 22.9.
Right. Yeah.
So but it is, and now very rarely, like that 1 in 1,000 patients that have the heart disease, there are people with genetic problems with triglyceride, and there are other tests we can do too, and maybe it's relatively easy to work out whether somebody's got a genetic problem with cholesterol or triglyceride, because you talk to their brothers or sisters or their mother or father or their cousins or uncles, and they've got the same problem.
Yeah.
So, that's, sometimes people don't know, adopted people, and so they don't have that luxury of knowing their genetic history, and they have to work it out a bit more awkwardly. But it's rare that should be. Most 99% of people should assume they don't have any genetic problems, and the reason why they're taking a bit longer to resolve is because their target is a little bit further away and a little bit harder to reach.
Sure. What about, I've had a few people over the years, not many, but probably a handful, who have begun LCHF and their cholesterol has just gone through the roof. And I'm talking about here, obviously, total cholesterol and LDL. What's going on with these people?
On average, when you go onto LCHF, cholesterol should increase. The total cholesterol will increase, and the LDL cholesterol might increase. The HDL will increase a lot. So, if the LDL might increase by a little bit and the HDL will increase by a lot, everyone's cholesterol should rise a bit on LCHF. Now, there's lots of people say that, oh no, I went onto the diet and my cholesterol fell. Well, if you did nothing, 50% of people would have their cholesterols fall, because we never get the same number. It either goes up or down. So just by chance alone, it can fall. And so the errors of day-to-day changes in the amount of water you have, the food you had that day, the errors we have in the laboratory means you can go up and down. But on average, people on LCHF should expect that their cholesterol will rise, especially because their HDL is rising. Now, typically it only rises by a little bit. So your cholesterol, the average cholesterol in Australia is 5.5. So if somebody goes onto the diet, I would expect that their cholesterol goes up towards 6. And, for everyone that's concentrating on total cholesterol, they think, oh, it's a disaster. And doctors get anxious about cholesterol going from 5.5 to 6. more anxious if they've got that high-risk patient who's already had a heart attack and so on, who wants to get off their statin. So I think it's understandable. But as you say, Vicky, there's some patients who go not from 5.5 to 6, but from 5.5 to 8 or 9.
Yeah.
Now, here it's important because it could be that a significant part of that rise has been HDL. I mean, I was really lucky on the diet because my HDL went from about 0.9 to almost 1.8.
Mm.
So it almost doubled on the diet. And when you think about the balance between the HDL and the LDL, if my HDL doubled but my LDL only increased by 50%, I'm still well ahead because the good stuff is so much better.
Yep.
So when that happens, you should check the ratio, because the ratio may still have fallen. The total cholesterol to HDL ratio may still have fallen, even though the total cholesterol has gone from 5.5 to 8.
Yeah.
And that should be reassuring, because even though you've accumulated more LDL, the HDL on the ratio is telling you it's not in a small, dense form.
Yep.
And so most people who get to that cholesterol of 7 or 8, because they've stuck to the diet and they've got a really good HDL rise, their ratio has improved and there is nothing to worry about. So, and that's quite common I'm not sure, I haven't really seen any clear figures about everyone who goes onto the diet, but I think it's up to 10% of people that get that exaggerated rise on the diet.
Mm.
Most people have a mild rise, 10% have a really high rise. And then maybe 1% of people have a ridiculous rise.
Yeah.
So going from 5.5 or 6 to 15.
Mm.
Now, in a way, you can't increase your HDL enough to make that ratio look good.
Yeah.
The ratio is going to look bad. Now, with those patients, we don't completely understand them. But when we're starting to, but there are some things which can do that, which we need to be on the lookout for. And one of them is if a patient's has got thyroid disease and they go onto a diet, they often get an exaggerated response like that. Mm-hmm. But it's not because of the diet; it's because their thyroid disease hasn't been managed. Yeah. So a low and inactive thyroid. Mm-hmm. So one of the first tests I do when you get this exaggerated cholesterol rise on the diet is check how the thyroid's working.
Yeah.
It's an automatic thing for every doctor in the world. If there's a high cholesterol that's unexplained, you should check the thyroid function. And so that would be one of the first things I do. Mm-hmm. And then the other tests are awkward. They're all to do with genetic problems. So, and they may be looking at LDL profiling. We haven't talked about that, but we can have a close look at LDL and see how small and dense it is. We can have a look at LDL to see whether it's got any funny proteins attached to it. Yeah. There's a funny form of LDL called LP, lipoprotein little a, lowercase a, and that's a genetic form of LDL that is hard to control. And so we've noticed some patients with exaggerated responses have LP little a, so it's important to know that. But I'm not happy to say, but I have to admit we do not understand all of those. My record, because I get a lot of emails around the world. Somebody went on to LCHF in New Zealand and their cholesterol went from 5 to 25.
Wow.
Now, there's something strange about that person's metabolism. That does not happen in 10,000 people.
Yeah.
And until we understand that sort of rise, you have to sort of temper what you're doing with the diet. Maybe in that person, you go onto the diet, reach a goal, and then get off the diet, mm-hmm. Yeah. Or something like that. or go onto the diet. Don't stop your statins, reach your goal, and then get off the diet.
Yeah.
But because the diet has, losing weight is beneficial from anybody's point of view, whether you've got a cholesterol of 5 or 25.
Yeah, absolutely. All right. Well, I think one last question is for people on LCHF, and those who are maybe just starting off. Are there any other blood tests that you would be recommending that they get done or that they keep an eye on?
Yes. My favourite test, which I've said in some of the YouTubes, is something called hemoglobin A1C. So hemoglobin A1C, hemoglobin is the red colour in your blood, and A1C is a form of that hemoglobin that has glucose or sugar stuck to it. And so in patients who have high sugar levels, they have more sugar being stuck to hemoglobin, and so they have a high hemoglobin A1C. So this is the best way to diagnose diabetes if the hemoglobin A1C is above 6.5%. But we're also coming to understand that a healthy hemoglobin A1C, so it's a bit like those cutoffs, say 4.5 for total cholesterol and so on. So if your hemoglobin A1C is above 6.5, that's bad. You have got diabetes.
Yeah.
But what's the ideal level? You don't want to be anywhere near 6.5, do you? So the ideal level is 5.6 and below.
Mm-hmm.
And those people with hemoglobin A1Cs between 5.6 and 6.5, or 5.7 to 6.4, those values, in most countries in the world, they're considered to be pre-diabetic. Yep. In Australia, we haven't defined that yet. We've just said, well, they're not diabetic, but they're not healthy either. We don't know what they are. Well, we know what they are,
yeah.
And they're not healthy. And in a lot of the LCHF studies where they've got a diabetic who's got an A1C above 6.5, it's relatively easy to get it below 6.5, so they're no longer diabetic. But ideally, you want to get it under 5.6, where they're absolutely normal again.
Sure.
And I have to admit, with LCHF, most people who are successful on their diet not only get below 5.6, they're down towards 5.2 or 5.0, even lower the younger you are. So that is my favourite test. And it does relate to small dense LDL because, strangely enough, even though I'm telling you small dense LDL is really bad, the thing that we think might be even worse is if you stick glucose onto small dense LDL.
Yeah.
So, and that might be the reason why diabetics get so much more heart disease than everyone else, because they've got small dense LDL because of the triglyceride, and they're sticking glucose to it. So when when I look at somebody who's got small dense LDL present, my immediate reflex is, what is their hemoglobin A1C? Yeah. You've got small dense LDL present. Are you also sticking glucose to it? Mm-hmm. And the hemoglobin A1C will tell me that. And so, and if they've got a small dense LDL and say the hemoglobin A1C is well in the normal range, like 5.2 or 5.0%, really good, I'm much less worried about their small dense LDL.
Yeah.
So hemoglobin A1C is so good. It tells you how close to diabetic you are, how far away from diabetes you are, whether you're making that small dense LDL that you might have more harmful. It's really a very, very good test. And from our point of view in the lab, it's one of the cheapest tests available. Much cheaper than doing small dense LDL sizing. And you don't have to fast for it. And yeah.
Well, that's a great overview, and I think everyone will find it extremely useful, as do I. I always learn something new when I listen to you, Ken. So thank you so much for sharing all of that. And I think the take-home message is that in most people, the large majority, a low-carb, higher fat diet is really going to be beneficial at the end of the day.
Absolutely. I mean, we've got a lot of baggage to deal with in our views of cholesterol and our views of fat in the diet and so on. But those people who are lucky enough to understand this new wave of thinking, they're going to benefit. And I've got no doubt in my mind that over the next 5 or 10 years, this will be a way of life for most people in the world, not for those lucky few who find a dietitian like Vicky Curiel who help them find the magic.
Crossed, Ken. We're hoping for that.
Yes.
Yeah. Well, thank you again. It has been fantastic having you with us. And maybe we'll chat again sometime soon, and there'll be some more info to learn something about.
Pleasure. Thanks, Vicky.
Okay. See you soon. Bye-bye.
Thank you. Bye.